Hello everyone, today I'll be taking another VivaLive session with QQSphere on the subject of otolaryngology with the topic ear, and the subtopic will be chronic suppurative otitis media. So let's start.
Welcome to this session. We will be focusing on chronic suppurative otitis media. To start, can you describe the anatomy of the middle ear cleft and its contents?
The middle ear consists of tympanic membrane, the ossicles, malleus incus stapes, eustachian tube, and two muscles, tensor tympani and stapedius. And it also has mastoid ear cells.
That's a concise overview. Now, consider a 16-year-old boy presenting with clear, non-foul smelling discharge from the right ear for several months, which increases with an upper respiratory infection. Otoscopy shows a central perforation. What is your primary diagnosis, and what would be the key differentiating features from chronic suppurative otitis media with cholesteatoma?
The initial diagnosis would be of chronic suppurative otitis media, and the differentials will be cholesteatoma, chronic otitis externa, tuberculous otitis media, any foreign body, or neoplasia.
You have listed some reasonable differentials. However, for that previous scenario with a central perforation and mucoid discharge, what would be the most direct diagnosis? And could you explain the specific differences between that and a cholesteatomatous presentation?
A cholesteatoma presents with keratin debris and bone erosion.
Yes, that's a key distinction, the presence of keratin debris and bone erosion. Now, coming back to the clinical presentation, how would you differentiate between the safe type of CSOM with a central perforation and the unsafe type, often associated with cholesteatoma? What are the clinical pointers?
The safe type or the tubotympanic type affects the pars tensa. It involves the eustachian tube and rarely causes dangerous complications, while the unsafe type, atticoantral or cholesteatoma, affects the attic or pars tensa. It is unsafe because cholesteatoma causes bone erosion, damaging the ossicles, facial nerve and inner ear, leading to dangerous intracranial complications.
Excellent distinction there. You've covered the site and the potential complications well. Now, regarding hearing loss, if you suspect a patient has chronic suppurative otitis media, what would you expect to find on tuning fork tests, specifically the Rinne and Weber tests, assuming it's a unilateral issue?
In case of CSOM, the Rinne test, which compares the air conduction to bone conduction, it shows negative. It is negative because bone conduction is more than air conduction on the affected ear, while the Weber test lateralizes to the affected or poor ear.
That's right. Your assessment of conductive hearing loss in this case is accurate. Now, what would be the general management principles for both safe and unsafe CSOM? What steps would you take for each?
It includes tympanoplasty, which is the reconstruction of the eardrum, and sometimes the ossiculoplasty also. And we can go for mastoidectomy in case of unsafe type to remove the cholesteatoma.
You've mentioned surgical principles, which are certainly key, especially for the unsafe type. For the safe type, what about medical management first? And when would you consider surgery? Also, what preoperative investigations might be useful before any procedure?
I don't know. Can you please explain?
Certainly. For the safe type, medical management focuses on control of infection with oral toilet and topical antibiotics, and sometimes systemic ones, to dry the ear. Surgery is then planned once the ear has dried, often for tympanoplasty to repair the perforation. Preoperatively, pure tone audiometry is essential to assess the hearing loss, and sometimes a high-resolution CT scan of the temporal bone might be done for unsafe cases to check for hidden disease or complications. Is that clearer?
Yes, thank you.
You're welcome. To conclude, can you mention a few potential complications of untreated chronic suppurative otitis media, both within the temporal bone and intracranial?